Thank you very much, and thanks again to the organizers for having me here. So I want to talk a little bit about lipid apheresis, some historical aspects, a little bit about the present and then the future. So the background, obviously, lipid apheresis is the mechanical removal of lipoproteins from the circulation. It's like dialysis for dyslipidemia, generally being focused on LDL, but you can remove other lipoproteins, lipoprotein little a, triglyceride-rich lipoproteins, and we've been using it when conventional therapy is either not sufficiently effective, homozygous FH, not tolerated, or just simply not available. So where does it all originate? Well, in 1975, Prof. Gil Thompson from the UK published an experience of two patients with homozygous familial hypercholesterolemia who were treated with plasma exchange. And these were two young female patients, and essentially their LDL cholesterol was reduced, and symptomatically their angina seemed to get a little bit better. So that's where it all started. And just to remind you, plasma exchange being the original therapy, essentially what you have to do is you have to take the blood from the patient, separate the red blood cells from the plasma, and then plasma exchange is actually a very simple procedure. You just take the plasma and throw it in the drain, and then replace, usually with an albumin or some other type of solution. It's obviously not very physiological, because apart from the lipoproteins, you're getting rid of immunoglobulins, clotting factors, and a whole lot of other things. But patients do tolerate it surprisingly well for many years. And to answer Prof. Landsberg's question, this is really what was offered in South Africa, plasma exchange. And the reason why it was offered in South Africa is because we have incredibly cheap albumin. So it was always cheaper to do this procedure than to go and buy one of the specialized kind of kits. And there are a lot of other lipoprotein specific techniques, and I don't want to go into too much detail, and people can argue what is your preferred technology, but essentially HELP system, you precipitate lipoproteins using heparin, Dali system, polyacrylate, or you can have dextran sulfate, or there is lipid filtration or antibody-based systems. They're all in a way targeted to remove LDL cholesterol. Some of them remove lipoprotein little a as well. And then there is a specific lipoprotein little a column that uses an antibody for apoprotein little a. So LDL reduction, how much you reduce the LDL is really a function of the apheresis time and how much plasma volume you're treating. You should aim to reduce the LDL at least as a minimum by 60% per session. And then you can perform this apheresis twice weekly, weekly, or every 2 weeks, and or some other interval. The more often you do it, the better LDL cholesterol control you get, but of course it becomes more expensive and it's more inconvenient for the patient to do it very, very frequently. So traditionally, the interval has been 2 weeks, but some other countries have been apheresing more aggressively with more regular treatments. And this is really just to show you a graph. How much LDL removed per session is really correlated with the circulating LDL, but the more important is the rebound. So the Dutch studied this in quite a lot of detail, what will happen with the various lipids once you stop the apheresis. And obviously time zero is just after the procedure is completed, and what you'll see is ApoB, LDL, lipoprotein little a start increasing again, and certainly by 2 weeks you're back to baseline. So if you only do once every 2 weeks, your patients will have lipids that go up and down a little bit like this, and there's a formula to work out the time averaged LDL cholesterol that you're achieving with your therapy. Now, what about outcomes? Does this actually work? Does it help patients? And certainly, you'll find lots of publications of impressive regression of mainly cutaneous xanthoma, but also some tendon xanthoma in patients who are treated with apheresis. Now, there are no cardiovascular randomized controlled outcome trials for this type of therapy. It's just not possible. You can't do sham apheresis for 5 years in patients. And so when we look at the data, we look at the comparisons between cohorts who were apheresed or not apheresed, cardiovascular event rates before and after starting this therapy, some imaging data, biomarker data. I'm just going to show you a brief selection of some of the data that we have for apheresis, not complete in any way. So, quite recently published data from the pediatric homozygous FH cohort study. So this combined data from the HIC registry and another registry, and then patients who started apheresis in childhood were matched with controls according to sex and baseline LDL. And what you can see here is these are the patients that were treated with apheresis over here. These ones didn't have apheresis. And you can see we're getting about a 30% LDL reduction in the non-apheresis group and about a 55. So there is an impact of apheresis, but it certainly doesn't solve the problem for most patients with homozygous FH. But what we can see clearly looking at both cardiovascular death and atherosclerotic cardiovascular disease is that there is a benefit from apheresis. So these children with homozygous FH who started apheresis in childhood benefited and lived longer, had fewer events. There's an imaging study done in Japanese patients looking at apheresis, so coronary angiogram, IVUS, and comparing groups who were treated with apheresis and not. And essentially, just to show you some of the data, mean lumen diameter was greater in the apheresis group, plaque area was smaller, lumen area was bigger, vessel area, again, all going in the correct direction, but a relatively small study. It's an expensive therapy. We have a little bit of data for LPA apheresis. LPA apheresis was really only done in Germany and a little bit in Russia. This is a study from Russia. They took 30 patients with ischemic heart disease and high lipoprotein little a, generally more than 100, and they gave them atorvastatin or LP little a specific apheresis, and then they followed them up with coronary angiography at baseline and 18 months later. And essentially what you can see here, a modest reduction in the lipoprotein little a, from about 106 to 72. LDL didn't differ significantly, but once again, there were some improvements in the angiographic parameters. No clinical outcomes, just much too small a study. This is data from a German single center. What they're showing you here is event frequency in the patients before and after starting. And if you summarize that data in a graph, yes, there are fewer events in the patients post-apheresis. Now you've got to remember these patients were started on LPA little apheresis because they had a lot of events. And then generally people won't have that many events. So the data, you have to interpret it with caution. It's not a randomized trial, it's purely observational, but it also suggests benefit from this treatment. And then a few words about severe hypertriglyceridemia. Generally, you would plasma exchange in this scenario. It's been done acutely either in patients who have hypertriglyceridemic pancreatitis or are thought to be at high risk for pancreatitis. Now, the benefit is uncertain. We have case series showing I apheresed 5 patients and they got better, but I can write a case series, I did not apherese 5 patients and they also got better. So we really do not have hard comparative data. There's some data showing possibly reduction in hospitalization, and there are isolated case reports of patients who were treated with this chronically in familial chylomicronemia syndrome. But because TGRLs turn around so rapidly, you need to do this procedure very frequently in these patients. This is what your exchange bag might look like in a patient with FCS. This is a patient who was pregnant and who we plasma exchanged. So current status, we have a lot of regional country variation, and it really mainly depends on is anybody paying for it or not. So high users are Germany, Japan, Italy, and then Russia for lipoprotein little a. Most commonly, still the indication is homozygous FH. In Germany, you can apheresis for heterozygous or statin intolerant. It really all depends what people are prepared to pay for. And then lipoprotein little a, I think it's only the Germans that actually do pay for it, and they'll probably stop doing so quite soon. So the future, I think LDL apheresis for heterozygous FH, it hasn't been commonly done in any case. And with PCSK9 inhibitors, bempedoic acid, ezetimibe, all the therapies we heard about for this day, I don't think you're going to need LDL apheresis for very many heterozygous patients, because we know evinacumab works in severe heterozygous FH as well. I mean, it's licensed for homozygous FH, but if you're really stuck, you have these other therapeutic options. For homozygous FH, the LDL receptor independent therapies such as lamidipide and evinacumab have allowed many patients to discontinue apheresis. If you look at the lamidipide trials, you'll see that patients are coming off apheresis. But again, these drugs are not easy to access. They're not available in all countries. And so lipid apheresis will probably continue to play an important role in the management of homozygous FH for quite a time coming, I think. The days of lipid apheresis are not over as yet. Little a apheresis, as I've said, not commonly done, but with the novel therapies, you can see these dramatic reductions in lipoprotein little a. I don't see us having an indication for lipoprotein little a specific apheresis in the years to come. Once these therapies are available and licensed, we'll be able to deal with lipoprotein little a elevations quite easily. Hypertriglyceridemia, I think, it's a low evidence zone. It will continue to be used ad hoc in patients with severe hypertriglyceridemia, either who have pancreatitis or where the doctors are worried. Once again, we have new treatments in the hypertriglyceridemia field, volanesorsen, olezarsen, plozasiran, and we may be able to get better triglyceride control and then have less patients who are at risk of pancreatitis. But I think we will still see this being used in the acute care setting when patients present with triglycerides that are very, very severely elevated. So in conclusion, lipid apheresis is an important technique that for many years was one of the very few options to manage patients with extreme lipid disorders. As we all know, the early days, statins in homozygous FH, if you're lucky, 20-30% LDL reduction. Bile acid sequestrants, well, your patients will hate you and it doesn't really work that well. And that was kind of it. And then apheresis was the only option for these patients. Once again, unfortunately, cost prevented many patients from accessing this option. It was most valuable and is still most valuable in homozygous FH. But I think the indications and the need for apheresis is going to be continually decreasing in the years to come. Thank you very much.